everyone. Many Canadians feel a sense of pride when it comes to our healthcare system, but just last year, a think tank ranked the healthcare systems in 11 high-income countries, and Canada came second to last, just before the United States.
Okay, if that wasn't eye-opening enough, the Globe and Mail recently published a deep dive investigation into the issues within our healthcare system. And one of the journalists behind that investigation is here now to help us face the music on what needs to change exactly here. Robyn Doolittle is back here at The Social. Welcome back to the show.
Thank you. I'm so excited to be back.
Robyn, thanks for your work on this. We're coming up on Canada Day. There's a lot of pride in our country. And in particular, we tend to get really proud and defensive about Canada's healthcare system. But can that pride be a barrier to having productive conversations about what needs to change to make it better for Canadians?
Calling it a barrier is almost an understatement.
Yeah.
I think the attachment that Canadians have to the idea of what our healthcare system is, and I stress idea, I think we'll get into this more, but the reality versus what's actually happening is very different. But that attachment absolutely prevents us from doing what needs to be done to fix our healthcare system. The reason, of course, is that we're right next door to this awful situation in the United States where a cancer diagnosis can bankrupt you.
Yeah.
And that fear of the United States has prevented us from doing what needs to be done to make our healthcare system great.
So you say, Robyn, that you didn't realize just how broken our healthcare system was until you started this investigation. So give us a reality check. And I don't know how to ask this question, like, how broken is it?
You know what's so funny? I think so much of the discussion right now is, oh, we have to do X, Y, and Z before it gets really bad, before this happens. I'm not saying this to be depressing or to scare anybody, but I do think we are in the worst case scenario in some ways. It's starting. I mean, there's not some sort of cliff that's going to be our healthcare system breaks, right? It's a slow boil. And what we're seeing now is huge numbers of Canadians don't have family doctors. You can spend the entire day waiting in an emergency room right now for a broken arm, surgery backlogs, wait lists. I mean, if you have had anyone in your life have to deal with the healthcare system right now, you know how terrifying and frustrating it is. And yeah, we are there right now where things are really bad.
Okay, you just mentioned a whole bunch of issues, right? Wait lists, shortages, all of those things. But there was a narrative that emerged, you know, when COVID broke out, that COVID was to blame for all of these problems, or had the majority of the blame for all these problems. How true is that narrative?
The pandemic certainly made us more aware of our healthcare system. I think regular Canadians having to interact with it, and it really cast a spotlight on it. But yeah, things were bad before the pandemic.
Okay.
So
Yeah.
my colleague Tom Cardoso and I, who worked on this story, we started doing this at the beginning of the year, around the time that Ontario was about to go into another round of really restrictive public health measures. And at the time, health leaders and politicians were saying, these steps are needed so that hospitals are not going to be overwhelmed. And I think a lot of people were extremely frustrated at that moment. Like, how is it that a few hundred extra COVID cases and hospitalizations can tip a healthcare system the size of Ontario's? So that's where the premise of this story started, with hospital capacity. And what we found was that before COVID, in the week that it was discovered in Wuhan, in provinces across the country, our ICU acute care capacity was at 95%. We did actually not have the ability to absorb these extra cases. And as nuts as that sounds, that's really the case. And our really stretched hospital capacity is a symptom of many more fundamental ills. And that's where the investigation really took us.
So one of the major problems that you've discovered and are writing about in Canada's healthcare system is that we talk about it as a whole, but truly, as we all know, healthcare is administered province by province, territory by territory. And that kind of patchwork system is something that you say is actually working against us. So explain that to us.
Yeah, this was a huge eye-opener for me. Let's back all the way up to the beginning of Medicare, the beginning of what we think of as Medicare. Canada's never really had a proper kind of public universal healthcare system. It started as an insurance program. It started as this idea, I break my arm, I go to the hospital, I'm not the one that signs a check at the end of it. It's we're insuring services within a hospital. And then from there, doctors outside of hospitals were covered. And then from there, other things. And it's kind of this piecemeal system where the bill all goes to the same place, but nothing is connected. So as you mentioned, we don't have one. We have 13 different provincial and territorial systems. They're all a little different. Within those systems, there are hospital systems, there are regional systems, there are pharmacy, primary care, long-term care. None of it is connected. It's all silos with their own managers, budgets, goals. If you've ever had to interact with the system, you know you're navigating between different places and no one knows what the other one's doing. Think of the waste and inefficiency that happens in this. And more important than the money, the poor care that happens from this lack of integration.
Interesting.
And you also point out that another, problem with Canada's healthcare system is how doctors are paid. So what is the relationship between how doctors are paid and the kind of care that Canadians are getting from the healthcare system?
So this is another example of that lack of integration. Doctors don't work for the hospital that you might see a doctor at. They are essentially independent contractors. They're small businesses. They do a service and then they bill the government. They have the privilege of working in the hospital. So doctors are paid on the volume of patients that they see, the work that they do. Hospital budgets are really complicated, but in general, they're not paid for volume. So you have these like misaligned incentives. No one in the system is compensated for health outcomes, really. No one is, compensated, gets a bonus for efficiency or being good stewards of public money, for patients doing really well. And this is kind of what we talk about, where we integrated these different pieces, everyone would be moving in the same direction.
Well, okay, so now we have to talk about that word, the P word. Right, privatization. So a lot of, as you mentioned right off the top, a lot of people are resistant to that because, as you said, it makes us think about the country down south in comparison. So do Canadians over-villainize privatization and what it could mean and how it could look in our country?
I think when we talk about privatization and we think immediately of the United States, it's proper to, I think many would say, villainize that version of it.
Right.
There are lots of things that need to happen in the healthcare system to fix it. Integration, more funding, it's been atrophied forever, better data, measuring outcomes. And some would say there is a room for more private dollars. First off, 30% of Canadian healthcare is already privatized. I know we don't want to think about that, but that's the case. So mental health, for example, huge strain on society, on health, on our healthcare system, outside of a hospital situation is not covered. If we look at adding private dollars, what would that look like? And for example, let's say we've had a specialized clinic for cataract surgeries. So people just go to this one clinic, get a cataract taken out, it's a conveyor belt, it's all moving very efficient, but it's the public system that specialized place is working for. So you're still not paying for it. The public system is paying for it, but a private clinic is billing the government for it.
Does that help with the backlog?
That would free up, what experts would say is it's freeing up, rooms in hospitals to do other sorts of things that is less efficient. So that's kind of where you can do, you can have a real benefit to some privatized services.
That hybrid.
Yeah. That other universal systems do, by the way. The UK, Australia, there's elements of this in those countries.
Okay, so everyone said COVID, rude awakening to realize just how broken the system is. Is that going to be the fix that it's going to take to actually ultimately make the changes necessary?
Okay, by the end of this decade, all of the baby boomers will be senior citizens. People are living longer than ever. They're living with chronic diseases, which is a huge medical success, but it costs a lot of money to keep people alive with complicated diseases. This problem is only getting worse. COVID has been a taste of it. So we need to do something. And what actually needs to happen is that people at home need to not freak out when political leaders and healthcare leaders say, we've got to make some drastic changes. We got to start small, trying new things, and giving people the wiggle room to actually fix this problem. Because this has been so politicized, it's paralyzed us.
Robyn, it's always so good to see you because you're doing the good work and telling the stories that we need to know. Thank you so much for coming back, and hopefully we'll see you again soon.